All right, good evening, everyone, and welcome once again to this installment of our highly popular FAA Safety Team LTA Outreach Series webinar, coordinated in cooperation with the Balloon Training Academy, a FAA Safety Team industry member and training provider. Today's webinar is on the medical certification process. Our featured speakers today are the Federal Air Surgeon, Dr. Northrup, Dr. Hatrup, and Brad Ziegler, and I will introduce them more in a moment. My name is Adam McGee, and I am president of the Balloon Training Academy, a FAA Safety Team lead representative, and designated pilot examiner for hot air balloons out of the Des Moines, Iowa FSDO. Together with Chris Manti and David Hintz, two of the best FAST Team program managers in the country, we are proud to continue this highly successful safety outreach aimed at improving airman knowledge and mishap prevention. We are proud to reach over 3,300 balloon pilots via this outreach over the last 19 months and provide timely and relevant information directly from the FAA. Huge thank you as always to Chris, David, the Des Moines, Iowa FSDO, and the entire National FAA Safety Team for helping behind the scenes with these webinars. This presentation is intended to increase audience knowledge and awareness for the benefit of safety of flight. The material presented does not supersede official regulations or guidance or policy. If a conflict arises, those regulations, guidance, and policy shall prevail. While the topic tonight is medical certification, the speakers will not be able to answer questions concerning your specific medical conditions and your specific medical certification process. Also, because the NPRM concerning medicals for commercial balloon pilots is not final, there might be questions the group cannot answer at this time. Play around with the on-screen controls to get some familiarity. If you have a question, type your question in the Q&A section of your menu, and don't be bashful. Please do not use the comments box for your questions. Please use the Q&A box. We're all here to learn, and we might learn something from your question. If we can't get to your question in time, we will follow up later via email. As I mentioned earlier, our featured speakers tonight are Federal Air Surgeon Dr. Northrup, Dr. Hatrup, and Brad Ziegler. Dr. Northrup is the Federal Air Surgeon for the FAA. In this capacity, she leads the Office of Aerospace Medicine in Washington, D.C. She leads strategic management of the FAA's aviation medical programs, which oversee all pilots. Together with the Deputy Federal Air Surgeon, she shares responsibility for the direction and management of all FAA medical programs. Dr. Hatrup is an FAA medical officer, received his bachelor's degree from Wichita State University, a master's in public health from Harvard University, and a doctorate from Vanderbilt University. He is retired from the U.S. Air Force, in which he spent the majority of his career in aerospace medicine. He is board certified in aerospace and occupational medicine, and he is a CFI and enjoys flying airplanes, helicopters, and gliders. Brad Ziegler is has been a certificated pilot for more than 28 years and has logged more than 20 years in the aviation safety industry. He is presently with the FAA Flight Standards General Aviation Commercial Division, focusing on issues related to airman certification and training. He has worked extensively on policy and implementation of regulations for both drones and manned aircraft operation, and serves as the program lead for the Basic Medical Eligibility Program. Brad holds an ATP remote pilot. He is an active general aviation pilot and bases his Cessna 182 in the Washington, D.C. area. So you can tell we have quite the lineup of speakers tonight, and we sincerely appreciate having these FAA leaders and decision makers on to speak directly to the ballooning community. I can assure the audience that they are real people, they are not robots, and they aren't out to ruin ballooning. So they are pilots just like you and I, and they're working towards the same goal, which is safety. So without further ado, it's my pleasure to welcome the Federal Air Surgeon, Dr. Northrup, and thank you for joining us, and I'll let you take it away for some opening remarks.
Awesome. Thank you very, very much. This is quite the honor to address this group. I can assure you that Over the past 15 or so months, we've made incredible strides in the aeromedical certification process within the FAA. And Dr. Hattrop and Mr. Ziegler will go through some of this with you. But rest assured, we stand on our promise to make this as painless as possible as we move through the airman certification process with everyone. We've taken incredible strides with working on improving our letters so that they're clear, working with our stakeholders to be sure that we're meeting their needs. One of the recent things, or one of the things we're about to roll out, is the ability for an airman to see where their medical is in the process. After all, if you can see where your pizza is from the time you order it till it hits your door, airmen should be able to see where their medical is. And we're not stopping there. We're going to continue to work with everyone to make sure that we get as many people in the air as safely as possible. So you don't really want to listen to me all that much this evening, so I'm going to turn it over to Brad and Lee because they've got the bulk of this presentation. I'll be listening in the background. Thank you.
Thank you, Dr. Northrup. And we can go ahead and jump to the next slide here. And again, my name is Brad Ziegler. I am the project lead for the rulemaking that we're talking about here, specific to medical certification for commercial balloon pilots. So this evening, just a couple of things we want to talk about here. I'm going to give you a brief status of where we are on the rule, kind of talk a little bit about our medical certification requirements, and then I'm going to hand it off to Dr. Hattrop, and he's going to go through and get into some of the details about medical certification and some of the questions you might have about how to obtain a medical certificate. And we'll finish off with a Q&A, and we'll absolutely try to answer as many questions as we can. As Adam noted, there may be some things that we just can't talk about this time. So let me go ahead and, okay, so one thing I want to mention, I noticed looks like we have more than 140 folks on the webinar here. That's great. And just looking through, I recognize several names from the comments that I've gone through. We received about 200 comments on this rule, and I can assure you I've read each and every one of those comments. So we're in the process of reviewing comments, and basically where we stand from here. The rule got published back in November. The comment period has closed. That closed back in January. So now that the comment period is closed, we basically take back your feedback and move on to basically finalizing the rule. One of three things can happen at this point in a rulemaking project after an NPRM, a notice of proposed rulemaking, is issued. One of three things can happen. One is nothing, which I don't expect that to happen. Two is the rule goes out exactly as published. And three, the rule goes out but with some changes. So to what degree there are any changes, or to what degree what comes out, we won't know until the thing gets published. And I say that, I don't mean that as a royal we, I mean it as truly, even the rulemaking team, rulemaking projects do have a life of their own. So even we won't know what actually gets published until it goes through the full FAA review process. So in terms of time, that's still to be determined. I wouldn't expect anything. I wouldn't expect it to go much longer than the end of the year. As to, and from that point on, when the rule goes into effect, that's going to be based on what the effective date is published in the rule. So we will know that when the rule gets published. So basically, and we can go ahead and jump to the next slide here. One of the things I also wanted to mention is that the background on the rule is that it was initiated as a result of a act of Congress. So, going back many years, there were multiple NTSB safety recommendations regarding ballooning, but as we all know, there was an accident back in 2016 that generated a lot of awareness within the FAA, within the industry, that initiated the provision with Section 318 in the 2018 FAA Reauthorization Act, which basically directed the FAA to act on medical certification. So that happened. The FAA formed a team and initiated a rulemaking project in July of 2019. Now, why the rule didn't get published until 2021, well, lots of things happened. Obviously, COVID-19 certainly derailed things for us. Rulemaking is based on prioritization and resource allocation, but we were able to finally get the rule out back in November. As I mentioned, we got quite a few comments on the rule. We received about 200 comments. As I mentioned, I've reviewed them all. Basically, what we do when we receive those comments, we categorize them based on the theme of the comment. Lots of themes started to come up, and what we will do as part of the rulemaking process is we will consider each and every one of these themes and look at, under what, basically, what is, what are the themes of the comments and what makes sense from a regulation standpoint. But again, keep in mind, the Reauthorization Act gave us a very specific directive. So the FAA, in writing a rule, has to abide by the statutory requirement to meet that requirement. So basically, we have to take that into consideration. This is a little bit different from other rulemakings that aren't directed by an act of Congress. Some common themes that we saw, a lot of people noted that the medical certification doesn't include random drug and alcohol testing. A lot of comment feedback was based on size of balloons and recommendations on or suggestions of using another type of medical eligibility, such as basic med versus a second-class medical. We had quite a few different comment themes. We will address each and every one of those comments in the final rule. Our objective as a rulemaking team is to make sure that anyone who submitted a comment, a reasonable comment that's within the scope of the rule, that we've addressed that question and provided a legally sufficient response. Whether that results in a change to the rule, that's to be determined. But nevertheless, we do look at these comments. We do consider them. It's not as though we just throw them in the bin. They are things that we actively consider and review. Like I said, we've got TBDs on when the rule goes into effect. So you'll know when it gets published, and of course, we may provide guidance at that time if there's any details that need further explanation. But the final rule will basically explain the rule in quite detail. If you read through the NPRM, you know that we tend to be very detailed in explaining our justification, our reasoning for establishing various elements of the rule. So next slide. Real quick, I just kind of want to talk about the cascade of medical eligibility requirements Starting from things like gliders, light sport aircraft. No medical certificate is required for light sport. You are required to hold a driver's license. About 5 years ago, Basic Med came online for powered aircraft pilots who are exercising their private pilot privileges. Basically, it's a set of requirements to an alternative path to alternative path from medical certification. So that's what established Part 68. Basic Med is essentially a program that really focuses just on aircraft. That was basically separate from the medical certification program. So we're not going to talk a whole lot about that today. 6153, I want to talk about that for a moment. And 6153 is the universal medical eligibility. And essentially, that provision states that no person can fly an aircraft if they know or have reason to know of a medical condition that prevent them from safely operating an aircraft. So that applies to everyone. That applies to you all today, even though you do not hold you're not required to hold a medical certificate. That also applies to medical certificate holders, although once you're required to hold a medical certificate, the verbiage changes just a little bit in that you're required to meet the requirements of that medical certificate. So it's more specific to the requirements in Part 67, which is medical certification. Let's go ahead and jump to the next slide here. For actual medical certification, there are 3 classes of medicals. For persons operating powered aircraft exercising private pilot privileges, they're required to hold a 3rd-class medical. It is generally good for 24 calendar months, unless the examination takes place after the 40th. It's good for 24 months, unless they have the exam before their 40th birthday, in which case it's good for 60 months. In other words, 5 years. A 2nd-class medical is good for 12 months, and that is required for any sort of commercial certificate privileges. A Class 2, of course, after 12 months, conveys the privileges of a 3rd-class medical for the remaining period of time. So, even if you have a 1st or a 2nd class, the privileges do cascade. And of course, a 1st-class medical certificate is good for either 6 months or 12 months, depending on your age, and that applies to persons exercising airline transport pilot privileges. So for purposes of commercial ballooning, the focus is going to be on 2nd-class medical certificates. And if we can go to the next slide here. Okay, and I am going to take that and hand it off to Dr. Hatrick, and he's going to talk about medical certification.
Good evening. A couple things before I start on my portion of the presentation. First is Dr. Northrup did not mention that she is a pilot herself, as is her husband. He's a retired airline pilot and former F-16 pilot, and both of her kids are private pilots, and they live on an airport and on a couple airplanes. So she's pretty heavily invested in that. That's what she does for a living. The other thing is, you may be wondering why Mr. Ziegler was discussing all this information on medical certification. It's because you probably heard him mention a couple regulations, and they were both under Part 61. Flight Standards owns the medical certification rules in regard to how long they last, which is dependent on the type of certificate, your age, and also what type of certificate you need for what particular type of activity, whether it's commercial, airline, private flying, that all falls under them. What the medical folks do is we determine what the requirements are to actually hold a particular class of medical. And that's what I'm going to address now. So when we look at medical certification, if you walk into the AME's office, and AME is an aviation medical examiner, it's an individual designated by the FAA to perform medical examinations on behalf of the FAA, very similar to what a DPE does in the pilot side, where they do an examination to determine if you're fit for a particular certificate. We have AMEs do an examination to determine if you're fit for a particular medical certificate. But if you see the AME and everything is okay, you'll get a regular certification. Now, sometimes there's additional information that's required. You still get a regular certification, meaning that it will expire in accordance with what's in Part 61. Sometimes there are conditions that the AME can issue where they have to retain information. And sometimes they'll give something called a SOTA, which is a statement of demonstrated ability. That would be for a defect which is permanent and not thought to be something which is going to change. There are also special issuances, and there are two types of those. There are the special issuances that the FAA retains the decision-making authority on, and the information has to be forwarded to the FAA for a determination, at which point an authorization letter is generated, typically along with the medical, if everything is okay. But for certain conditions, after the initial special issuance, the AME is authorized to issue the medical to you and then forward the information to the FAA for review. So the big advantage of both the CACI and the AASI, the AME assisted special issuance, is that if you have the information necessary and you do meet the requirements for that medical and for the evaluation, you walk out with the medical. You don't have to send the information to the FAA and then wait for us to review it and issue the medical to you. Slide, please. So we talked a little bit about a regular, and that just means you meet the criteria under Part 67, which is the medical portion of the Federal Aviation Regulations, also known as 14 CFR, Code of Federal Regulations. You can have some limitations on that. It's not uncommon for people to have them for corrective lenses, either for distance or near or both. You can also get a letter of evidence. Many of the folks out there with a color deficiency have one of those. I mentioned SOTA for a static defect, and I mentioned CACI as well. Again, those will require additional records, but the AME maintains those. And as I said, if you have the information necessary, you should be able to walk out with the medical. So that's something that was instituted about 10 years ago now, I think. And it has really helped as far as reducing the lag from the time you apply for the medical until you actually have one issued to you. Slide, please. Again, AASI, the AME assisted special issuance, that does need to be granted by the FAA initially. So the initial medical will be deferred. But then if everything looks okay, typically we will authorize the AME to issue the recertification medical, but they still have to send the information off to the FAA for review. Again, the benefit is that you walk out with the medical if you are qualified. However, this may have and probably will have time limitations on it other than what would be on your ordinary medical. So suppose you had an AASI for a condition and you were limited to 1 year on that. That would then limit your medical to 1 year, even though you might otherwise be qualified for up to 5 years if you were under 40 when you got the medical for a class 3. Yeah, you still do get the medical, and the recertification process tends to be fairly smooth for most folks. More serious, and that information does need to be sent to the FAA. However, we do tell you what's going to be required in advance, and if you get us the information frequently, there's no delay. In other words, you can still have a valid medical in your pocket while you're waiting for us to review the information. And if everything goes well, and frequently it does, you can have the special issuance reapproved in time for you to continue flying without any hiccups whatsoever. A lot of the folks who work for the airlines will work with different institutions to help them with that process, and they continue. It really does not cause that much of an issue in their careers. But there are responsibilities. The responsibility for the FAA is to review the information as promptly as we can, come up with a fair determination, and if at all possible, to do so safely to get you back in the cockpit. But there's responsibility of the individual as well as the AME. What I want to focus on here is your responsibility. First, you do need to find an AME, and there's a link there, and these slides will be available to you to find an AME if you don't know how. The other thing is just to talk to people in the community. Most folks know who an AME is if you're around an airport much. If you have not seen an AME before, would recommend that you discuss any underlying health issues, because it's quite possible that there will be information that's necessary, but if you have that in hand, you might be able to walk out with the medical, whereas if you do not come into the appointment with the necessary information, you should anticipate there probably will be a delay, because the AME is only allowed to hold the medical for 14 days before they have to send it into the FAA. There are reasons for that I'm not going to go into, but be aware that once you are in the AME's office, the clock does start ticking. So have that in mind as you're getting information prepared for the AME. I highly suggest that you look at the AME guide. We're working on that to make it more readable, but the information that you need is frequently in there. It will outline the criteria. It's updated on a regular basis, and it's a good place to start. If nothing else, it'll indicate to you if you potentially have any issues which you need to discuss prior to showing up for the medical. Slide, please. So you found out that you need to send information. What do you need to do? Well, the first thing is we need, or the AME, depending on what the condition is, we need complete and we need legible records. Probably the thing that slows the process down the most is if we get incomplete records, if we get testing that we did not request and did not get the testing we did request, or we get copies which are illegible. Other things which slow the whole process down, which means it delays you getting your medical, is sending in multiple copies. This is a foot stomp type thing for those of you who've been in the military before. If you send multiple copies, we need to scan all those in. We need to review all those, and then we need to go through and make sure which are duplicative and which are not. And that actually sometimes is more difficult than looking at the same stack of material, but if they are independent evaluations as opposed to duplications or triplications sometimes. So please do not fax it in, send it in by FedEx or UPS, and then mail it just to make sure we get it. That really does bog things down for us. Avoid sending in superfluous information. We will tell you what you want. Please send that to us. Do not send everything in your medical record because we have to look at it. And that, again, slows the whole process down. And if at all possible, send us a single submission, because that way it makes it much easier to get into your record. What happens when people send things in piecemeal is that we'll get part of the information, and then we will take your record, we will generate a letter saying, we need to have this. That letter will be sent to you, and not uncommonly, the information that we want then arrives while the letter's out, and it just creates confusion. So please, if you can avoid doing that, do so. It's to your benefit. So next question, or next point is the philosophy. I know this is not what everybody believes. I've seen the t-shirts up at AirVenture. We're not happy until you're not happy. That folks like to wear it, AirVenture and elsewhere. But actually, our goal is whenever we can possibly get someone to yes, we try to get someone to yes. So if you have an adverse health effect or a adverse health diagnosis, we are going to look for what treatment can be done to mitigate the condition, what evaluation can we do to determine if you're an and how often we can look at you. And there are many conditions right now that we have been able to return to flying that at one point basically were the end of someone's career. Not too many decades ago, if you had insulin-dependent diabetes, you did not fly again. And then the door cracked open and it was allowed for third-class medicals. And recently, within the last couple of years, we've been allowing people with class 1 and class 2 medicals to fly while on insulin. There's specific protocols that they have to follow. A lot of folks are now back in the cockpit. And that's because testing has improved, treatment has improved, and we can now do something safely that we could not do not too long ago. And that list keeps expanding. Slide, please. So the health continuum, you look far to the left where it's green, healthy. Those are easy decisions for us. If you look at someone who is very ill, that's also very easy for us to make a decision, not the way that people would like, but if you have an active seizure disorder and you're having seizures 2 or 3 times a week, you're not going to fly. It's just not safe. You're probably not going to drive. The people that cause us to take more time and there's more testing and sometimes more expense, and we are sensitive to that, are the group in the middle, where they're not super healthy, they're not super sick, they're kind of in between. And that's the group that we spend most of our time on, trying to make a determination, can we let this individual return to flying? So when we look at risk assessment, next slide, please, we consider what's the likelihood that there is going to be a recurrence? If it recurs, how serious is it going to be? What can we do to mitigate the risk? Sometimes that's treatment, sometimes that's testing, as I just said. Sometimes it's by keeping people on a fairly short observation period. Typically, if we give a special issuance, it's for a year, but it can be shorter if we're worried that things can deteriorate. But if we check more often than every year, perhaps we can be comfortable that the risk for the next 6 months or so is going to be acceptable, and we'll let somebody fly. Next slide, please. So I stole this slide from one of the folks up there at headquarters that I work with. I mentioned that Dr. Northrup is a pilot. In my intro, I'm an inactive CFI, but I am a CFI. But all 4 of the executives that we have in aerospace medicine do have their pilot's license. We have a psychologist who's instrument rated. 2 of our 3 psychiatrists have a private. We have there's another CFI besides myself. We have 1 physician who actually is former military pilot. And a number of the regional flight surgeons and many of the doctors in Oklahoma City have a private, and some are aircraft owners. So we are sensitive, sympathetic, and empathetic to your desire to keep a medical. Those of you who already have one, and for those of you who are anticipating that you might have a need, we understand. We truly do. We have medicals as well, and we want to keep them. So scenarios that we have that are concerning. One is someone has a condition which can impair their ability to safely fly, performance impairment, a cognitive problem, someone who has underlying angina, but which is chest pain due to a cardiovascular condition. Folks will avoid treatment because they don't want to have a diagnosis. They don't want to tell the FAA, or they will get treatment, but they don't want to tell us because they're afraid. That can actually be problematic in that sometimes you compromise your own health. And so while we recognize that people feel threatened by the risk of losing their medical, we strongly encourage you to make sure you get the appropriate health care. For a few years, I actually helped pilots get their medical back. I was on the outside looking into the FAA, coordinating with folks in Oklahoma City to get medicals back for people, and actually had phone calls from people at the door of the emergency room saying, hey, I've had chest pain, and I think it's probably okay, but I want to find out what I need to do to keep my medical before I go in and get seen. And of course, the answer is always going to get taken care of, because if you have a devastating heart attack and don't have any cardiac function, or worse, if you die, you're not going to get a medical back. So always, always, please make sure you take care of your health. The other concern we have is in individuals who have something which is perhaps cognitive issues tend to be in that area. And many of us have seen that in our colleagues. We've seen it in our family, perhaps, or friends. And probably one of the more common scenarios that we see in the United States is taking away the keys from a parent who's they're elderly and no longer safe to fly. Recognize that this can happen to us. All of us are going to reach a point where it's probably no longer safe for us to fly. So please listen to what other people, family and friends are saying, as well as other pilots. It may keep you from injuring yourself or someone else. Next slide, please. Give me one. Oh, no. All right, slide, please. Brad, can you still hear me?
I can hear you.
Okay, I just lost thing. I'll be right back. I'm going to have to reboot. My Pulse Secure just went offline.
All right, why don't I take this then? Can you go
Do you
back?
mind?
Yeah, I got it.
Thanks.
So there's lots of reasons that people will tell us on why they don't want to tell the FAA something. There's the hassle effect. They'll ask me to go all over and send all kinds of records. This financial, some of this is expensive. We understand that. Delays, they'll take forever to make a decision, or doom, they'll go around me forever. And I hear that a lot, particularly with people with mental health conditions. And the simple fact of the matter, next slide is, please, denial is actually really an uncommon event. So we get, on average, year over year, 385,000 plus or minus applications per year. And that goes back a decade or better. Slightly less than 10% of those end up with special issuances. About 1% plus or minus end up in an initial denial. Typically, that's when somebody's admitted to a condition and we have to ask for additional information. But when somebody provides all of the information, less than 0.1% end up in a final denial at the federal air surgeon's level. So these really are pretty rare. Now, that's not to say there isn't a bit of a back and forth sometimes as people get these documents to us and we get a chance to review them. Next slide. You back up there, Lee, or you want me to keep going? Yep, now you're muted.
Yes, I am now.
Okay, all yours.
Okay, thanks. So we do have education out there. One thing that we have recently started is called the Pilot Minute. There are 5 of them out there right now. And for years, we've had something called the AME Minute, where we pick a timely topic that has had a lot of questions that are being raised to us, and we will address it. Dr. Northrop is now hosting these, and we talk about some issues which are concerning to all pilots. It's aimed more at the airplane community right now, to be honest, because that is the largest community that we have, but we plan on expanding this over time. This is not going to be a 2 or 3 and done. This is an ongoing effort that we're going to have. But what our goals are with some of these is not only to educate you on what you could do to fly more safely, but also we want to make sure that we decrease the deferral rate. So bring the proper information, which we just talked about a few minutes ago, to the AME. Make sure that you have appropriate survival skills. We do have aviation physiologists down at CAMI, and we do offer courses on aviation survival, similar to what's offered to military pilots. And in fact, many of the folks that we have within the FAA are former military and bring that skill set with them. We want to make sure that the answers we give you are not convoluted, that they're straight. So please reach out for questions. And we want you to be looking at us for your airspace medical information rather than some of the other sources out there, not all of which provide correct information. I'll leave it at that, but just when you read something on the internet, be careful of what you read. Just standard advice there. Slide, please. So here's some links. I'm not going to belabor this point because, as I said, these slides will be available, but you can click on those and there's just a wealth of information out there. As well as at the bottom, you can see there's some other stuff that's coming up. Actually, I've got acceleration issues there, but I think you just touched on that, Dr. Rick. Slide, please. And some more information. And slide, please. So that kind of, and we are open to question. Again, just a reminder on the rules of the road. We really can't make too many comments on the rulemaking process itself. The comment period has closed. If you have questions on the rules and we are able to answer them, we will. If you have questions on medical certification that do not relate to a personal situation, we would be happy to discuss those as well. So, and with that, I will turn it back over to the moderator to look at the questions and determine to whom they go.
All right, good evening. Good evening, everybody. This is David Hintz. There's a few questions left, but not very many. Everybody's been doing a fantastic job of jumping in there and answering a lot of the questions. One of the questions that came pretty early in Bradley's thing was why not all balloon pilots need a medical, not just commercial pilots? I guess I never really understood that either. Or was there any ever thought about that?
So I'll go ahead and answer that. And I'll start with a historical background. And airman medical certification goes back to the beginning of civil aviation back in the 30s. And I found evidence of a requirement for medicals for ballooning type of operations going back then. Back in the early 70s, late 60s, there was a major change to Part 61, which actually created balloon as a rating on private and commercial pilot certificates. Prior to that, it was its own standalone certificate. At that time, that certificate specifically did not require a medical certificate in order to exercise privileges. In all of my research, one thing I didn't find was a explanation of why or why not we did or did not require a medical certificate. And unfortunately, back in those days, the agency was not quite as detailed in terms of explaining changes in regulation. And I'm sure it's written somewhere in a mimeographed sheet of paper somewhere in the bowels of the FAA headquarters. However, I never found a good explanation. But just to address the question of, well, why are we not making that requirement for private balloon operations to require a medical certificate? I want to start by saying that we do consider balloon operations to be a relatively low risk operation in terms of the spectrum of risk. So when we talk a lot in the agency about the risk continuum, and we generally consider balloon operations, particularly non-commercial balloon operations, to be among the lower risk operations out there. So for that reason, we did not see a justification within the rulemaking to expand medical certification requirements to those exercising their private pilot privileges at this time. That said, commercial balloon operations, the FAA has long held that when you conduct an operation for compensation or hire, you're held to a higher standard. You're held to a higher standard of oversight. You're held to a higher standard of operations. And the public expects that. And I think the Section 318 of the Reauthorization Act is a reflection of the families of the Lockhart accident, really speaking out through the arm of Congress to, dictate to the FAA, this is something that you all need to address. So while we didn't extend medical certification requirements to all types of balloon operations, we did acknowledge that in the case of operations for compensation or higher, there's a higher expectation, and that's the rule.
All right, thank you very much. Hey, Adam, we've got a couple questions on some of the links that were in the PowerPoint. Could you pull that back up and display those links again so people could take a screenshot or a snapshot of that? That would be great.
They're also in the chat.
Not all of them made it to the chat for some reason. I don't know why. So that was, because that's what I tried to answer and they didn't agree. So if we could get that back up there, that'd be great. Golly, a lot of these are getting answered. I don't understand what this question is. Is an AFib controlled with medication an automatic disqualifier?
It will lead to an automatic deferral, but depending on the medication and any associated symptoms, we have many, many pilots flying on AFib that are controlled with medication or status post-ablation. So, I mean, in other words, they've had an electrocardiac thing that happened to stop the processing. But yeah, we have lots of people with AFib flying.
All right, and good to know. Designation type has a choice for first class AME or employee examiner or HIMS. Which choice would apply for a medical for a lighter than air?
But you got this, do you want me to take it?
Yeah, I can do it. For lighter and air, all you're going to need is a second class, and any AME can do that. The people who are senior AMEs are then allowed to do a class 1 medical, which is what's required to exercise ATP privileges, which is what's necessary essentially for Part 121 operations, the captain of an airliner. And then the HIMS personnel, the HIMS AMEs, are specially trained to work with individuals, some of whom have drug and alcohol issues. And it's not necessary to seek a HIMS AME unless you do have that as a problem that would require a special issuance for that. But for most people looking for a class 2 for lighter than air, any AME should be able to help you.
All right, sorry about that. Answering another question here.
Now, there have been several questions in here. What does a physical exam include? How does that work? So essentially, if you are in the process of applying for an airman medical certificate, if I can talk tonight, you will end up going into the MedExpress application site, creating an account. Do yourself a favor, use an email address you use frequently and a password that you'll remember when you go in there. You'll fill out what used to be the front of the 8500-8. So that's who you are, where you live, your background, your history, the medications you're on, doctors you've seen in the last 3 years. You'll certify everything. You'll acknowledge the pilot bill of rights, and then you'll submit the record to our system. It sits there until the document is imported by an aviation medical examiner. And if it's there longer than 60 days, it simply disappears. Within 60 days, the AME pulls it in, reviews the front of the form with you, gives you a chance to change any of your history answers, so he can update, or she can update that. Ancillary people might take your blood pressure, your pulse, check your eyes, height, weight, all that lovely stuff, do your urinalysis, but the AME must do the actual exam. There was a question in here, is this automatically going to require a rectal exam? No, unless it's otherwise clinically indicated. And for the ladies, the same occurs to a GYN type exam or a breast exam. But you should expect somebody's going to look in your ears, eyes, nose, and throat, listen to your heart and lungs, push on your belly, check your reflexes, watch you walk. I mean, it's standard physical exam. If they don't find anything, or if anything that would require a deferral, they can issue your medical on the spot. They are required to transmit to the FAA within 14 days, at which point the records are screened. If there's nothing of significance, it goes to file. If there's something that makes us raise our eyebrows or something that pings one of our alerts, we take a look at it. So it's usually pretty straight. Better than 95% of people that walk in, walk out with a medical. And as I already ultimately will end up with the medical as well. Lots of really good information in the Guide for Aviation Medical Examiners. And that's available online. The thing is posted in the chat. If you have questions about it or you have a condition, you can look it up. You can take the document to your treating providers. They can help you collect the information, or you can call an AME or the regional flight surgeons or any of the numerous pilot advocacy groups. Okay, Lee, did I forget anything? Or Judy? By the way, Dr. Judy Frazier is also online and been answering questions.
Actually,
just one other point, Dr. Northrop, which is an AME cannot open the medical, even though you've done your portion in MedExpress, until you provide the unique identification number that's given to you.
Right, the confirmation
So
number.
if you're not sure to whom you're going to go see, you can just leave it there. As Dr. Northrop mentioned, after 60 days, it will go away if no action is taken on it. But you're the one that makes the decision on whether or not to let the AME and subsequently the FAA to see that information. But then once you do push it to us, we need to look at it. We don't have an option at that point.
one thing I was going to add is for many folks listening in this evening, this may be your first medical application that you've ever completed. And I'll say that the first one's probably the hardest one to do. And I'll also add that the hardest part of obtaining a medical certificate is probably going through the application process, particularly if you've never done one before, because you're going to need to collect a fair amount of information. One of the things I do, whenever I've applied for a medical certificate, is I open up my insurance provider's online web portal, because it has all of the lists of medical appointments I've had, which makes it real easy to provide the information they're looking for in the application, because you're going to be required to share information about medical visits over the previous 3 years, medications that you're currently taking, and any medical conditions that you've ever had. So, put a lot of time and effort in making sure that that application is filled out as fully and completely as possible. It will make your visit with the AME go much smoother, because ultimately all of that information is going to be used to evaluate your medical condition, and getting it right up front makes the process just a lot easier.
All right, well, very good. We've got just a few questions left that I don't know if really apply to what we're talking about this evening. So Adam, if you want to take over for final thoughts, that'd be outstanding. Thanks everybody for joining us tonight.
All right. Yeah, thank you. Thanks everyone for joining us, and thank you to all our speakers for joining us and giving us the overview of medical certification, and definitely something new for us balloonists, and we'll look to be going through the process in the future. Just wanted to let everyone know you can mark your calendars for our next LTA Outreach Series webinar. It'll be March 16th at 6 p.m. Central Time. Patricia Mathis, the National Manager of the FAA Safety Team, will be joining us to discuss the FAA Safety Team and share how you can participate and take an active role in improving aviation safety. So once again, wanted to thank our speakers for joining us tonight. And Chris or David, if you guys have any final thoughts, or you can go ahead and close us out.
Can I make one last comment?
Yep.
I think Dr. Northrop got interrupted. It was garbled on what I heard when she made the comment that 95% of people walk out with their medical. And then I think she was saying that over 99% eventually get a medical. One additional point is the vast majority of that 1% that do not get their medical eventually is because they never sent the information to us that we need to see. They just stopped for whatever reason. There are very few people actually that we have to disqualify after we have all the information because it's not safe to let them fly. So well over 99% of the folks out there would get a medical if they provided everything to us.
All right. So yeah, thank you all for joining us. Speakers.
Thank you, Adam. Thank you for inviting us.